Well, good afternoon if you're joining us from North Carolina, and good day wherever you're joining us from. We're very pleased to have you with us. I'd like to welcome you to today's webinar on North Carolina Medicare-Medicaid integration and advancing whole person care. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, and this webinar represents a collaboration that includes a range of participants. The participants include the support from Arnold Ventures, a good deal of time and effort from a dedicated team at North Carolina Department of Health and Human Services, as well as engagement from national and state integration leaders, a range of community partner and very interested stakeholders from throughout the state, and our team here at Duke-Margolis. I'd particularly like to thank Aparna Higgins, Senior Policy Fellow at the Center, one of the leaders of this project, as well as Rastana Kaufman, who you're going to hear from shortly, Karina Sorensen, core faculty member at Duke-Margolis, Montgomery Smith, policy analyst Samantha Repka, research associate Mark Japinga, research associates all at the Center, in addition to collaborators at Duke and elsewhere, as I just described. This is a project that's very important to us. It fits into our broader agenda on healthcare transformation, especially for people who get fragmented care today and have the most needs and have often been underserved traditionally. Getting at the issues in our healthcare system that really matter to people's needs, meeting their personalized needs, accelerating the implementation of actionable models that are effective in lowering costs, improving health, and going at the root causes of poor health, unmet social needs, as well as issues related to inequalities, are key parts of our mission, just as supporting North Carolina state government's efforts on approaches to transform the way that we pay for healthcare, moving to paying for health, and supporting the delivery of innovative care models that meet all of these patient needs through the transition to managed care now in Medicaid, and potentially through further steps like this one, is a key part of our work. Today, our team is going to present a high-level overview of findings from our qualitative and quantitative research, as well as evidence-based recommendations for Medicare-Medicaid integration in North Carolina. I want to emphasize that these are recommendations shared and developed, but that we're sharing today were developed by Duke-Margolis. They reflect input from a wide range of stakeholders, but this is not DHHS positions. In fact, Medicaid transformation for dual eligibles, as we'll talk about today, is an issue where DHHS and other key policymakers and leaders and stakeholders throughout the states have important decisions to make in the months and coming years, and this effort is intended to guide and support those decisions. The recommendations were designed with the goals of supporting, again, a beneficiary, person-centered integration strategy that simplifies the care experience, providing comprehensive, affordable whole person care, and improving health outcomes for the dual eligible population in North Carolina. Achieving these goals requires payment and care model reforms. It requires engagement from healthcare leaders, health plans, communities, and other stakeholders. It requires attention to reducing the care fragmentation and administrative burdens that are too challenging for healthcare providers who are stretched thin today. And it, again, focuses more on the actual needs of patients. And I want to give a special thanks to Arnold Ventures for supporting this work and their broader efforts for improving care for complex populations that has enabled us to bring together this report and all of you today. With that, I'd like to introduce Ariel, the Vice President at Arnold of Healthcare at Arnold Ventures, for a few opening comments.
Thanks so much, Mark. I'm Ariel Muir, and I lead Arnold Ventures Complex Care team. And our work is dedicated to improving the systems of care serving low-income older adults and people with disabilities. And like Mark described, we also have a vision of a healthcare system that holds the whole, delivering high-quality, affordable care that coordinates across providers, settings, benefits, and systems. Yet our public healthcare programs, specifically Medicare and Medicaid, were not designed for that. Integrated programs that put the person at the center of a coordinated system hold tremendous promise to correct that system fragmentation, but only a fraction of those who could benefit from those programs today are actually enrolled in them. Today, the most direct route to advancing integrated care is through the states. That's why, as part of Arnold Ventures' Advancing Medicare-Medicaid integration effort, we're supporting states making a meaningful commitment to standing up integrated programs. The grants we are making to states and their partners, like Duke-Margolis, will help make evidence-based, consumer-informed policy development and implementation a reality. Today's focus is on North Carolina, to the potential that exists when evidence, engagement, and strategic vision is brought to bear. And I'm so grateful for the stellar work of everyone who contributed to the project so far, and to the engagement and prioritization by North Carolina policymakers. But today is not only for North Carolina. When I look around the country and DC, there is something about this moment that feels full of possibility for transformative change across the country. Maybe it's the pandemic and the awakening that it caused about the vulnerability of low-income people, people of color, people with disabilities, people in nursing homes. It also feels like kind of the confluence of some policy moments. The great work done by the Medicaid Commission MACPAC, the wind down of the federal demonstration program, new opportunities for states with their dual eligible special needs plans. And just this year, we counted 3 hearings in the Congress with a specific focus on dual eligible individuals and 4 pieces of federal legislation introduced. These all feel like opportunities to harness, to really improve integrated models and move toward achieving the promise of integrated care for all people who are dual eligible for Medicare and Medicaid. So we at Arnold Ventures eagerly await how the work that the Margolis Center has done will accelerate transformation in North Carolina, but it can't stop there. This work is for beneficiaries, policymakers, and stakeholders in other states, and for federal policymakers who have a real opportunity to support system transformation nationwide. Thanks again for all your work and for coming today. Back to you, Mark.
Ariel, thank you. I really appreciate the emphasis on this. Does seem like a special moment with not just North Carolina, but other states, federal government partners, other policymakers very interested in this direction. One person who is critical for that is Cody Kinsley, who's the Secretary of the Department of Health and Human Services for North Carolina. DHHS oversees not just the Medicaid program, but other programs that have such an impact on the well-being of North Carolinians. And in this role, DHHS, under Cody's leadership, is taking important steps to create this integrated approach to person-centered care, including social services and a wide range of other considerations. Cody, thank you so much for joining us today.
Thank you, Mark. It's really great to be here. And thanks to the Duke-Margolis Center for leading this webinar today. And thank you, Ariel, for those really thoughtful comments, and to Arnold Ventures for their support of this work. I mean, I could not agree more that there is a very particular moment now. I think if the pandemic has taught us anything, it's that we're really all connected in health, and the health of our neighbors and our community members impacts us. We're not on an island. But at the same time, all the tools and the resources that we need to bring to bear to improve health and to drive health have to look across the entire spectrum of health and human services as we think about the investments that we make. So thoughts about integration and working together are really important for us from a strategic policy perspective. I'd like to thank the members of my team here at the department who have been working so hard, not only responding to the pandemic, but also continuing to invest in initiatives like this. You know, we can't wait one moment to get better, and investing in getting better right now is very important to us. We're entering now the 2nd year of Medicaid transformation here in North Carolina, and we're on the eve of launching tailored plans, which are specialized plans for individuals with complex behavioral health or IDD needs. These recommendations from the report come at such an important time for us to influence how we can decide where we need to be moving next and how dual eligible beneficiaries will fit into this transformation effort. When we talk about paying for health and not health care in North Carolina, we believe that no population offers a better portrait of what we need to do than dual eligibles. There's such an opportunity here to really invest in outcomes, and that's what we want to see. North Carolina has 275,000 dual eligible beneficiaries. There are significant diverse health needs in this population, and there's considerable challenges in navigating care across a very large state with heterogeneity in its rural and healthcare access infrastructure. We want to see dual eligibles able to pursue care across Medicaid that really reaches better health outcomes, but also, as Ariel mentioned, reduces disparities and invest in physical, behavioral, and social needs as well. So I'm really excited to be here to listen to this conversation. And I know that together we can move forward in a place that really promotes health across our state and our country. Thank you.
Secretary Kinsley, thank you so much for your time today, and especially for your leadership at this very special but very challenging time in healthcare reform and transformation. Now, I'd like to turn next to the Deputy Secretary of DHHS, who oversees Medicaid, and that's Dave Richard. Dave has been directly involved in Medicaid reform efforts, Dave, probably for longer than you care to remember, but has been particularly important in the efforts that we've just been discussing around new person-centered approaches to delivering and financing care. That includes in the Medicaid program overall, as we just heard about from Secretary Kinsley, where over the last couple of years, we've been in this transformation process, now moving from the core Medicaid population into some populations with special and distinct needs, but not yet dual eligibles. North Carolina has been an innovator in the space of integrating medical and social services with one of the first plans approved by the Centers for Medicare and Medicaid Services to bring in some direct supports for addressing those social needs within this goal of improving outcomes and lowering total costs of care. So it's a journey that's underway, but certainly not done, and definitely not yet done when it comes to dual eligible. So Dave Richard, thanks so much for being with us today.
Happy to be here, Mark. Look forward to this conversation. Thank you.
Well, we appreciate your taking the time, and maybe to start off with the points that Secretary Kinsley and I just teed up. You're in the midst of the biggest transformation in Medicaid, North Carolina Medicaid ever. What's your take on how it's going at this point in terms of getting to that vision of care transformation and some of the challenges and progress along the way?
It's a great question, and again, I want to also second Secretary Kinsley and thanking you guys for the work that you're doing, because our journey, we've been all with you and on most all of this, so we really appreciate that work. What I would say is that from the standpoint of the Medicaid agency, we think in general our first transformation, moving 1.6 to 1.7 million beneficiaries into managed care, has gone well. We're still, infants in this effort, though, right? So we're a year and almost a year and a half into it. But what we're seeing now is the beginning stages of where the promise of this transformation is beginning to happen. Real integration. We see that every day, because for this population, they are in the standard plans, and all of their services are authorized by the standard plans. So we're seeing that beginning phase of that. We think our providers are really engaging in a different way of thinking about integration. Some really great talk about collaborative care models and moving in different ways. But again, we're still early. So right now, we want to make sure we continue to do the blocking and tackling to get those things right. Really pleased with our efforts around social determinants, as you mentioned. So we've launched those pilots, we're moving forward. And as you mentioned, we're about ready to bring forth in April the much more complex population for our tailored plans, which we delayed from December, mainly to make sure we got it right for that group of folks. But the same promise of integration is there, and then ultimately move forward with a foster care plan for child well-being. And then I think the final phase of this is where we are right now, talking about dual eligibles. What does that look like? and I'm holding a report in my hand. I'm looking at it constantly. I think the recommendations are really, really terrific, and we can't wait to engage you more and everybody else more as we really begin the planning for launching our dual eligible program.
Well, thanks very much. And you're just describing the process so far. One of those key recommendations is to take a stepwise approach, to have that clear vision, to do the qualitative and quantitative analysis to support how you're going to go forward, but recognize that there is, as you said, a lot of blocking and tackling and just a lot of hard work and course corrections needed along the way as these different systems that haven't worked together before, social services, medical services, as we're asking healthcare providers to do new things with new resources and new flexibilities and supports. But it is care transformation. And so the stepwise approach and correcting along the way makes sense. But as you mentioned, and the main focus today is on the dual eligible population. So that's 275,000 beneficiaries here in North Carolina, 12 million or so nationwide that, Dave, as you know, have some of the highest and most complex healthcare needs, the most potential benefits from integrating social services that can help with their needs, can help with their caregivers and their complex medical problems, but often are have the least access, as we heard about earlier from Ariel, the least access to truly coordinated, integrated care. So how do you see, before we get into the details a little bit, how do you see Medicare-Medicaid integration completing, I guess, this vision of Medicaid transformation for the state?
One of the things, Mark, that has been, as you described it, is a journey, right? So when we first started, very, very great theories and where we should head and how we should move there. And frankly, when we first started, it's probably not fair to say, but so we've got the right plan in place. It's going to make sure as soon as we flip the switch, things are going to happen. But I think what we recognize, and clearly, right, is that the hard work on the ground. And so what I think about a lot is that care coordination is absolutely the key, right? It's the glue of everything we're doing. We're proud of the work in North Carolina because of that is really at the provider level. And I think that makes a lot of sense for us to do that. And as we think about integration of duals, I think that's really the key to this, is making sure we got the right care coordination for folks going forward. But because of that, it's the integration of all the things you've mentioned, right? I can't tell you how many times that we've had conversations with people about, I have a great position, they do great work for me, but really when I leave that office, I'm on my own, and because I'm on my own, I don't have access to the social determinants, the things that we're talking about in housing and food security and transportation. But what we really need is that glue to match it together. And then, oh my gosh, behavioral health services, right? So I think about dual eligible, and all we're learning about what's happening as people with disabilities, people are older, and things that they're facing coming out of the pandemic, but frankly, things that people were facing before that. So this real focused effort of how do we make sure all those things are together. And then clearly the real difficult work of integrating Medicare and Medicaid to make sure that we're not duplicating and that we're really doing the best interest for people. So it's an exciting time, but I think the work that we've done really gives us a nice foundation for as we begin to launch tools.
Yeah, I appreciate that emphasis on the supports needed to make sure that these goals of coordinated care, more personalized care, behavioral health integration for so many people are facing important stresses these days as we try to move beyond the pandemic. All of that requires, just a lot of foundations, electronic data interoperability, security, accuracy, new ways of working across healthcare organizations and health plans, other steps towards supporting integration. Now, there have been a number of notable new programs in North Carolina that have helped support these efforts, like the Healthy Opportunities pilots I mentioned before, the features in the waiver that directly provides some financing alignment and also accountability for addressing social needs and doing it in a way that improves outcomes, addresses total cost of care, and the like. Any key learnings that you want to highlight from the transition to prepaid health plans so far and all these supporting steps for healthcare providers who are transitioning to be advanced medical homes and with some new expectations about helping to integrate these services. Any key lessons you'd like to highlight before we turn to our next panel?
Yeah, I think a couple of things I've mentioned, and I should have mentioned earlier, is that health equity has become one of the key issues that we're recognizing, right? So obviously over the past 3 years with George Floyd's murder, and then frankly having the pandemic just shine a light on things that we've been missing. So really for us is that try to underpin everything, thinking about health equity as we're going through this process. The other thing is that I think we're hearing a lot of, and we hear it from our physician community, but we also hear it from a lot of our other providers who want to be a part of this, is that, we've got a lot of really, really smart people that do this work, all the folks from Duke, our team, brilliant people doing this, but folks are also going through a whole bunch of other things, right? So you think about coming out of a pandemic and how complicated that was, how other systems are interacting with that. So I love the idea. I think one of the things that that you talked about is it's how do we make things simplistic? That's the wrong way to say it maybe, but really make sure that we're doing is that we're not duplicative of other systems, that we're helping the provider community, because frankly, if we don't get them engaged at the right level, then we're really not going to make these change. But helping the provider community engage us in what are the best ways to make sure that we achieve these goals. So I think that's really one of the key lessons, is that our engagement has to be much more aggressive with providers and beneficiaries to really understand what's important to them, and then to make this system as smooth as possible for people as we make these transformations.
Yeah, I appreciate all that emphasis on engaging key stakeholders. Providers are a really important part of that, and couldn't agree more that they are feeling stretched today. So anything that can, make this job easier, the electronic data systems that work, standard approaches to measuring, reducing administrative burden, all of that's a critical part of contributing to the goal. Dave, any final thoughts before we wrap up? Again, really appreciate your leadership on these very important reforms, but still a couple of years in, but sounds like a lot of the journey still ahead.
A lot of still ahead. I think the only thing I would add is that, one is, again, we really appreciate the partnership with you guys and all of the other folks that have been engaged in this. We do get a lot of praise for a smooth transition to managed care. And what we like to say to folks is that frankly is in North Carolina, all of us together, right? Because people have worked really hard. And if we can keep that engagement, people all working together, I think we'll be successful in these new transformations as well. So thank you again for letting me be here and for the work you guys do.
Well, thanks so much for joining us today. And now I'd like to introduce Bristana Kaufman, who's a health services researcher here at the Duke-Margolis Center for Health Policy, also at Duke Population Health Sciences and the Durham VA. Bristana is going to provide an overview of some of the key options discussed in this recommendation to move towards a very integrated approach to dual eligible financing and care in North Carolina, and how to do it. Thanks, Bristana.
Well, thank you, Mark. And I'm glad to represent the project team and all of the people who have contributed to this work over the past 2 years. And going to the next slide, today we're just going to give a preview and present some options for integration that are based on our empirical findings, but this is really just skimming the surface, and I strongly encourage everyone listening today to please read the report. There is so much information that we won't have time to cover today. And like Mark mentioned, these are the Duke-Margolis recommendations. We don't reflect the position of the North Carolina Department of Health and Human Services. In the report, we'll actually discuss the benefits and challenges of each option that we present, and we'll need to evaluate these as we continue to learn more, as Medicaid transformation progresses in North Carolina, and we learn from the launch of the tailored plans as well. Next slide. So it was great to hear from Secretary Kinsley and Deputy Secretary Richard about the goals of Medicaid transformation and how the goals of Medicare-Medicaid integration are really well aligned. We certainly have an opportunity to build on the work the state has already done to support whole person care and bringing the experience of dual eligible beneficiaries to the conversation so we can improve outcomes and align care with their needs and preferences. So in the report, we'll define a lot of the terms that are in this vision. What is high value? How can we make care community-centered and truly support whole person care? And as a part of that, we defined some interconnected goals, and we prioritize goals that simplify the experience for beneficiaries and caregivers as they're trying to navigate two separate programs to access services. And we also prioritize reducing the administrative burden for providers. And of course, health equity is an important component of all of these outcomes. Next slide. So dual eligible beneficiaries have complex needs, and those needs vary across the population. So we linked Medicare with Medicaid claims data to define and describe different subgroups based on their different needs. And people could be in multiple groups at different times throughout the study period, but we focused on people who had full Medicaid benefits or full benefit dual eligible beneficiaries. And what we found is that nearly 2/3 were categorized as community well by our definition, which is still a very high need group, but they are relatively young compared to the other subgroups with more needs in the Medicaid population. So across all of these groups, including community well, more than half of beneficiaries had 6 or more chronic conditions. And compared to the community well, the users of long-term services and supports who are based in the community are older and more likely to live in rural areas. In the report, we also describe the Community Alternatives Program waiver participants and Innovation waiver participants. And the behavioral health user subgroup, we try to replicate the tailored plan eligibility using the claims data that we had. And we did this to help inform decision-making for the population who will be eligible for those tailored plans when they launch. And finally, we described the nursing home residents, which is a small but high-cost group of older beneficiaries with the highest rate of chronic conditions. So as we considered different options for integration, we thought about how to best meet the needs of these different groups. And next slide. Our qualitative work, we prioritize the beneficiary experience and building a beneficiary-centered model. And we really want to thank all of the interview and focus group participants. I know many of you are listening now, and we are grateful to you for sharing your stories and experience. We heard themes about the concept of having one set of administrative processes and materials, and ways to create a seamless experience and coordinate care across payers and settings. And the report will synthesize these themes, and this is the evidence that we used for building the beneficiary-centered recommendations. So thank you. And on the next slide, we list the 6 parameters that shaped the design of our integration options. So 2 of these parameters have the same recommendations for each of the 4 options that we're going to talk about next. So each of the 4 options we'll present today leverage the program of all-inclusive care for the elderly, as well as dual eligible special needs plans as the primary integration mechanisms to advance the vision for integration. And in North Carolina, both of these models have strong and increasing enrollment, and we wanted to leverage the current infrastructure to minimize disruption for the population. We also recommend phased implementation, phasing in more complex populations over time and starting with the community-based and lower complexity subgroups. So this way, the state has time to build the infrastructure and experience, and providers and plans have enough lead time to be fully prepared and hopefully minimize any disruption to beneficiaries. Also, just note that we're focusing on the full Medicaid benefit population who will be eligible for the Medicaid prepaid health plans. And on Medicare side, beneficiaries always have a choice. So they can choose a fee-for-service or other Medicare Advantage plan if they opt out of the D-SNP plan. And on the next slide, we show the 4 proposed options for integration using the D-SNP model in addition to expanding the PACE program. So option 1 is the most similar to the status quo. So they're listed here from least integrated to most integrated. And in option 1, unaligned D-SNPs will continue to operate in the state along with aligned D-SNPs, meaning those plans that have companion Medicaid prepaid health plans. So because unaligned plans would continue to operate, this is the least integrated, because in those plans, the beneficiary will still have 2 separate systems. And option 2 requires aligned enrollment for new enrollees. So it has similar challenges to option 1 because unaligned plans would continue to have 2 separate Medicare and Medicaid benefits and falls short of achieving the vision. And option 3, the more substantial step of adding service area alignment for Medicaid and Medicare plans is included. And that's important because it means that the D-SNP would administer a Medicaid plan that serves the same area as the Medicare plan. And this supports a lot of alignment in terms of the materials and the processes for the beneficiary. So the key challenge to this approach is achieving network adequacy, particularly in more rural areas. And option 4 extends on option 3, including service area alignment and moving towards exclusively aligned enrollment. So while this option is administratively complex upfront, it offers the highest degree of integration from the beneficiary standpoint in terms of process and administration and creating a concept of one. Because under this option, the D-SNP would include the same individuals who receive their Medicaid benefits through an affiliated Medicaid prepaid health plan. Since it's the same population in both plans, it really supports the opportunity for integrated processes, having the same materials that show one set of benefits on both the Medicare and Medicaid side. So in this option, we believe that this would provide greater opportunity for potential partnerships between the D-SNPs and the standard plans, as well as tailored plans. So option 4 is our recommended ideal end state for North Carolina beneficiaries, but there are many potential pathways to implement and achieve the benefits of this option. And so in the report, we do provide a potential runway that would support a phased approach for option 4. And it's really important to establish milestones and engage community leaders and beneficiaries too in developing a plan to achieve the benefits of this option, and know that it will take time to reach the full vision. And next slide, in the second section of the report, we describe the model components. So no matter which option is pursued, the state can leverage their Medicaid agency contracts and the D-SNP model of care provision to advance the vision and the goals for integration. So looking for opportunities to align processes across Medicare and Medicaid, as well as integrated assessments and quality measures. So we will share more in the report. And moving to the next slide, the report also discusses ways to measure success across 5 different domains in health outcomes and beneficiary experiences, as well as cost and use, access and quality, and very importantly, health equity. And so we identified opportunities to leverage the state's existing health equity initiatives, as well as opportunities for alignment across the Medicare and Medicaid measures. So finally, the next slide includes a quote that really crystallizes the key themes we heard in our interviews about a system of one. But this is a continuum, and so we want to keep moving closer and closer to that vision and that goal. And we've invited 3 members of our advisory panel throughout this project to participate in a conversation today about how Medicare-Medicaid integration can achieve the vision of whole person care. And next slide. We've invited Lena Sharma, who serves as the Deputy Director of the Center for Consumer Engagement and Health Innovation at Community Catalyst, where she works alongside the director to carry out initiatives focused on ensuring that community voices are represented in healthcare transformation. And specifically, Lena provides leadership and policy expertise to the center and its partners on improving programs and policies related to integrated care for individuals who are dually eligible for Medicare and Medicaid. And Tim Engelhardt directs the CMS Medicare-Medicaid Coordination Office. This office was created in the Affordable Care Act to improve services for eligibles dual eligible for Medicare and Medicaid. Prior to joining CMS, Tim was consultant with the Lewin Group. And Tom Roth is a practicing family physician with over 20 years of experience working in North Carolina. He currently serves as the president of Community Care of North Carolina, which is the largest and longest running medical home system in the United States. This physician-led organization builds and supports community-based healthcare delivery systems using care management and analytics. Welcome to you. Thank you for joining us today to have this important conversation. We've laid out a vision of how we would like to improve care for dual eligibles and this concept of one, but it is so hard to implement, even if everyone is doing their best. And so I hope we can talk through some practical steps and mechanisms that the state can use to move towards this vision of integration. And so, Tim, maybe we can start with you. And could you share how CMS works with states, specifically to enhance the beneficiary experience and achieve the state's goals for integration?
Well, thank you. In health policy circles, we often focus on integrated care really by focusing on aligning financial methods and incentives across Medicare and Medicaid. That's really important. But any of us who operate in like the prosaic day-to-day world know that we don't experience healthcare that way. We experience lots of times through like letters in the mail that we don't understand, and denials and approvals that we don't know what to do with, and customer service processes are confusing, all that stuff like that. And so these are twice as complex for dually eligible individuals. And so a big part of the promise of integrated care is really it's like integrating materials, the handbooks and the directories that people get. It's simplifying the appeals and grievance processes, and having as Dave mentioned, a care coordination infrastructure that's really more about the person than about which of the specific programs they're in. And so we've worked with a lot of states now on really moving the needle on some of these like day-to-day, but really important experience driving interventions like materials and appeals and grievances. It's been a big point of focus for us. We've made a lot of progress in the last several years.
Thanks, Tim. Appreciate that, and really sharing, what it looks like from the beneficiary perspective is really helpful. And so, Lena, given your work at the Community Catalyst and elevating consumer voices, what advice would you have for states who are striving for beneficiary-centeredness and making that process easier to navigate?
Thank you, Rostana. Well, let me start off to give a little premise about who Community Catalyst is, and that'll help some of where my thoughts are coming from. We're a leading nonprofit national health advocacy organization. We're really dedicated to a movement for health equity and justice. So we partner with local, state, national advocates and other stakeholders to really leverage and build power so that all people can influence decisions that impact and affect their health. And so we know health systems will not be accountable to people without a fully engaged and organized community voice. And so to your question, I'll provide a few overarching thoughts. One, I think it's really important, as the report even points out, it's honoring lived experiences. Dually eligible individuals as equal partners in integrated care policymaking and program implementation. They know best about what they need from their care and what they value in healthcare. And so a person-centered healthcare system is one that really respects and addresses individual preferences, needs, values. Our research on person-centered care has showed that when preferences are not taken into account, the outcomes are negative. States to really place value on meaningful community and consumer engagement. And so concretely, that means investing in structures, such as whether it's implementation councils, advisory councils, that really allow for community members to have an active, collaborative place at the table. So viewing the community as co-creators or co-collaborators alongside states, health plans, and other stakeholders that hold power. And that goes a long way to shifting that power dynamic. And finally, I'll say the approach to engagement with the community with cultural humility and patience. You know, the language that we use, the words that we use really matter. And what may resonate with us sort of in this policy world may not necessarily resonate with people, you know, in everyday plain language. And so terms like care coordination, integrated care, they're not an everyday language for people who move through their world and into the healthcare system for this population and for their loved ones. And so it's really thinking about that, taking a step back, thinking about the intersectionality of this population, you know, how their culture, their day-to-day, what it's like, where they live, all of that matters when it comes to thinking about a person-centered approach to really meaningful, authentic community engagement.
Mm-hmm. Thank you, Selena. Those are great points, and not just simplifying the processes, but even the language and the way we talk about care as we're trying to engage people is so important, and seeing it from their perspective. So we're really tailoring to meet them instead of expecting them to accommodate to meet us as a system. So Tom, I'd love to hear about the provider experience. You know, the beneficiaries, we need to improve the experience for them, but also the providers are in this day-to-day supporting those beneficiaries. And so the system also needs to be able to work well from the provider perspective. So how can the state think about improving provider experience, providing supports for them, and then communicating the vision for Medicare-Medicaid integration to providers?
Great, thanks, Rastana. And I really want to jump off from where Lena and Tim were going. And really, the good news is the state has had a really strong ground game with the other Medicaid transformations. But I think, you know, broadly, what we're trying to do is go from this fragmented system to a coordinated system. And I'll just give you some examples. So you're a primary care doc seeing a patient in follow-up who's been through a complex hospitalization, and they're dually eligible. And this patient is really works with two different systems, two benefit designs, two sets of policies, two payment systems, two sets of data. And so really the provider is flying blind and really doesn't have the information they need to take good care of this patient and this person and coordinate care. So really what we want to go to is a system where there's really advanced care coordination and care management. And we use that term a lot, but really what that is a team-based approach where even the beneficiary and the beneficiary's family's priorities are inputted into the care plan. And you've got primary care, specialty care, home and community-based services all on the same page. So the only way to get there is really a strong program around provider education, because this is a super complex system. And then strong data systems, because we use data to sort of put together the patient narrative, the patient's journey and experience. That's sort of our starting point. And then strong communication in this complex team. So I need to be able to communicate with specialty providers, acute care providers, home and community-based providers. All of us need to be on the same care plan. So quite a lot to do to get providers there, but I think we're in a good state to be doing this.
Absolutely, yes. The foundation, it was great to hear Dave Richard talk about the foundation and how it can support some of the ideas and a process for integration for duals. So another theme that emerged from our research was the importance of engaging community leaders, including beneficiaries, but definitely providers and other leaders throughout the process of integration, design, and implementation. So if we come back to you, Tim, and you know, at the CMS Medicare-Medicaid Coordination Office, you supported a lot of different states. And so who is engaged throughout the process? And then how has that changed with the new recent rule that's impacting D-SNPs?
Well, states and the federal government both have very important roles in serving this population. I think it's probably everyone on this knows the states really the drivers with federal matching funds for the Medicaid program and The federal government operates the Medicare program. And in a circumstance like this, both have big roles, right? States, when it comes to dual eligible focused programs like this, states get to make some of the big design decisions. The options that Duke has put forward are examples of things that are really within the state's control to make those decisions. But no matter what the state approach is, CMS at the federal level will still oversee and monitor and audit, just like we do other organizations that deliver Medicare services. So we review the models of care through which special needs plans, Medicare Advantage plans, deliver services and arrange that care coordination. We review the timeliness of connections to customer service agents, including through TTY and in alternative languages. So there's some like really important basic kind of auditing and oversight steps that the federal government does no matter what, no matter how a state has designed a delivery system for dually eligible beneficiaries. You alluded to it. We recently finalized some new mechanisms for states and CMS to work together and really enhance kind of the joint oversight process. I hope we'll have some chance to use those in North Carolina soon. But there's not just CMS and states, there's a third party here that's maybe the most important. It is the most important one. We also finalized new requirements that all dual eligible special needs plans establish what we call enrollee advisory committees. Our own work has shown us that really the most important perspective on performance is that of the people that we're all here to serve.
That's a great transition to Lena's work. And Lena, could you share some of the successful strategies for consumer engagement that you've seen in your work experience?
Yeah, sure. So, just what I said earlier, some authentic, meaningful engagement starts with investing in structures that allow for that. It's also, our research has shown that who are those trusted sources within the community and for states and plans to partner with them. So there's community organizations, advocacy groups, caregivers. And so when you are building those structures, whether it's advisory council or state level implementation councils, it's ensuring that those voices are also at the table. Ensuring that there's feedback loops in place. So for example, information that's being discussed or shared at these advisory councils is shared back to those who hold decision-making power, and that information is then back to the people who are serving on that advisory council. And so there's a feedback loop. There's accountability and transparency, and that creates trust and that creates buy-in. I think it's important to create inclusive environments when you're setting up structures like this. So thinking about, getting down to nitty-gritty and thinking about how, the timing of the meetings, how the meetings are held, ensuring that, there's respite care for people who want to caregivers who may want to participate, but that they can't if they don't have anyone to care for their loved one. And again, thinking about cultural humility and how these structures are set up to make sure that the community voices, they can authentically participate without feeling the intimidation of any power imbalances, thinking about intersectionality. And so, that lens is really important when you think about meaningful strategies to consumer engagement.
Mm-hmm. So this goes a step farther in not just convening people, but making sure that feedback loop is in place. Sounds like a really important piece of the process. And then that helps to build trust, right? Because people see that, you're actually engaging with them and their ideas in a meaningful way and understanding their perspectives. Thank you, Lena. And Tom, the healthcare providers, of course, have a critical role to play as well in the implementation process. So as the state is considering these options for integration, could you speak more about the infrastructure and resources that would be needed? You had mentioned data earlier on, and that's really the provider's window into the world of healthcare for that individual and their needs. So maybe we could hear more about, from the provider perspective, what are the resources that are most needed and types of education that you mentioned that might be helpful for providers.
Yeah, I think there are a couple of critical things, and one is this principle of care management and care coordination, we have great movement in North Carolina and the standard plan transformation, the tailored transformation of provider-led care coordination and care management. But I think when the duals transition, we'll have to have some time and resources to build those systems at the provider level. These are complex individuals. It's a complex program. It's going to take a tremendous amount of education. If you were to poll a primary care physician or an ER doc or a specialist about what does Medicare cover versus what does Medicaid cover, you would be amazed. It took me 10 years to figure out who covers transportation, who covers home health, and all of those complexities. So I think what's different is that long ground game of education, and as Lena was talking about, really getting providers to the table, to the design table, to kind of help inform the design. One of our great tools we have is there's a lot of value-based purchasing and value-based care and value-based arrangements going on in North Carolina. So I think using the accountable care organization construct and really getting provider incentives aligned financially and from a quality perspective is a huge, huge opportunity. But in terms of resources, the other resource we need is time. This is going to take, over a year or more to really get this, do this correctly, get the basics installed correctly. So want to emphasize that piece.
Thank you, Tom. That's a great point, that the knowledge about both sides of care is not just a gap for beneficiaries and learning to work these two systems, but the providers have to do that as well. So the more that we can integrate should simplify the process for providers as well as beneficiaries and their caregivers. So Lena, coming back to some of the ideas that you raised about, cultural humility and making sure that we're accommodating diverse people and their perspectives, we really need to be able to address health equity, and it's a part of all of these conversations. But any practical steps for bringing that into an integrated program, I'd like to hear from your perspective. What are some ways that North Carolina can ensure that its integrated care model accounts for the heterogeneity of the duals population and moves towards that goal of health equity?
Yeah, great question. I want to sort of jump off of what Tom just said, time, right? Allowing for time to build capacity from the state side, from the plan side, from the provider side, and then allowing for people who are going to be in these programs to understand what this means for their care. I mean, we're talking about, two systems that don't traditionally work well together, intersectionality of all the different things that as dually eligible individuals and their family caregivers walk through. And then there's, the structural inequities, we think about race and racism. And so when we are building structures like this, it just requires time. It requires listening to people. And that's an ongoing piece, right? I would strongly encourage, North Carolina, other states across the country, ongoing listening sessions, town halls, however you structure them, for listening to people within the communities about their needs, about how it's working, and then taking that information back. And investing the resources to do that, and building that infrastructure that, that is critical to having a long-term success of an integrated care program. And the other piece that I'll say is, the data infrastructure that I think both Tom and Tim mentioned, and how important it is to have that investment right up front. Without the data that you're collecting, not knowing what it is, it can be challenging to make improvements into the program. And so it's important to collect both the quantitative data as well as the qualitative data that I mentioned with listening to individuals. That is really a critical piece of ensuring that you are addressing the needs of the duals population, the subpopulation within the duals population who experience even more complex care, people who need the long-term services and supports. And so I emphasize, when you're addressing the health inequities, listening, with active listening, with the intent that you're taking information back and then investing that right back into the community with improvements.
Mhm. Tim, did you want to follow up on opportunities to use data for health equity that you've seen in other states?
Yeah, well, I agree with everything Lena had said. I think to some extent, time, I think is really a proxy for something else, which is just tremendous attention to detail and execution of this vision. And that often takes time, but I think that's really what we're talking about. Is Mark called it blocking and tackling, and Tom called it ground game. You can tell it's football season, but it's really just that intense attention to successful execution is a big part. And on the data front, stratification of outcomes and other measures by different population segments, be it race or ethnicity or age or reason for eligibility or all these others, just such a foundational part of assessing health equity.
No, that's something they're already moving towards with Medicaid transformation in North Carolina that we can leverage in integrated models as well. I know we've only just got a few minutes left. Tom, was there anything you wanted to add from your perspective?
I think Lena and Tim said it really well. Let's get the basics right. Data infrastructure is a really big part of the basics. You need to know who your patients are and how what their journey has been like. But this has been a great discussion. Thank you.
Mm-hmm. Thank you to all three of you for joining us to really highlight the duals experience and how we can find opportunities to improve the process of care delivery, and then ultimately have better outcomes and a more equitable system for all of our dual eligible beneficiaries in North Carolina and then nationally as well as this work moves forward. So the report will be posted, the links are in the chat, and we'll be sending that to everyone who has registered. Again, we've just touched on the surface today, and I appreciate you joining us for this conversation. And I hope you will read the report as well.